Hi, and welcome to Week 10, Professional Communication, Healthcare Informatics, and Documentation. This week, we will be elaborating on healthcare informatics, in particular how it affects nursing, and some of the key competencies that nurses are expected to know in relationship to communication in a healthcare field, specifically with basic computer skills, information literacy, which we touched on in week 5, and information management. This week's readings were from Sewell and Thede, and chapters 1, 9, 10, and 17. So the reason why we need to touch on healthcare informatics is really nursing and healthcare is changing along with the technology that's happening all around us. And this has been going on for generations, but it's been rapidly growing over the last several decades. We think about how we have moved on from paper charting. We've been doing paper charting and paper ordering for as long as we've had written records. And in the last 10 years in particular, technology has allowed us to navigate patients across great distances. Our patients don't necessarily even have to be in the same city with us. So we talk about this because it's not just enough that we can reach out across distances. We have to be able to find the correct information, make sense of the information around us, and be able to be smart about the way we use our information to improve patient outcomes. So, at the center of the healthcare storm is nursing, because frankly, no one else in healthcare touches patients as often as nurses do. And by virtue of where technology is growing, nurses have an obligation to know how to use technology to have better outcomes for our patients. So in this respect, we look at all of the things going around. You see this kind of looks like a hurricane going around this poor nurse. And we look at things about infrastructure, things like bandwidth. There's certain hospitals that can't achieve high levels of acuity in rural settings because their internet capacity can't handle it. So everything that they have has to be carried from internal mainframes and really can't rely on internet technology. Then we have online care coordination and online care applications, policies and procedures that we're trying rapidly to keep up with how fast technology is going, but frankly, policies and regulations right now are not keeping pace with how fast things are growing. Consumer comfort with secure online transactions. Lots of lawsuits. We'll talk a little bit about breaches that have happened in healthcare where data has been compromised and stolen. So we're really concerned about that. Some people are more comfortable with it than others, and frankly, sometimes breaches happen and the patients aren't even aware of it or even what the ramifications are, but we will talk about that. Healthcare resolution for mitigation and malpractice insurance. And that's just about how do we protect us as healthcare providers with the vast amount of information that's out there. What are we responsible for? What do we need to be protecting? And, is healthcare in crisis? Well, since 2008, since healthcare, the affordability, uh, the Affordable Care Act in 2008, healthcare has been kind of in flux and we don't really know where it's going. So at the center of all of this is where we as nurses need to think about what our place is in order to manage all of this. So here's the important questions. How do we prepare nurses to lead in this changing environment? And how do we lead in this where things are changing so much. It's not exactly clear, except that the National League of Nursing and the American Nurses Association have developed competencies that are expected of every practicing nurse. And it's been kind of a challenge because you are special. You are only the third semester here at UW-Eau Claire that have received these competencies since they've been mandated by these nursing organizations. And every nursing student and every practicing nurse that has come before you has not had these competencies, has not had this nursing informatics content. But, and these include those that I've already talked about, but we'll talk about those in greater detail. So who makes these competencies? These competencies include the basic computer skills, the health literacy, and the health information management. And Tiger is one of those organizations that's a technology for informatics guiding education reform, and they came out in 2008 with a set of educational reforms saying our education system for nursing students has not been robust enough, and our nurses need to know how to use technology. And then the QSEN, which is the Quality and Safety Education for Nurses, right on the tails of Tiger. They were funded by the Robert Woods Johnson Foundation, which is very big in healthcare advocacy. And QSEN says, absolutely, we need to have these in place. We agree with it. And because of that, we're going to mandate that education for nurses have to include these nursing informatics competencies. The American Association of Colleges of Nurses went on board very, very soon after that, 2009, advocating it, and went so far as to define what exact competencies. There's 30 competencies that all nurses should have. And this isn't just for nursing students, this is for practicing nurses as well. But we haven't gotten far enough into this to be able to capture those people. And then the Centers for Disease Control and Prevention in 2010 expanded that education, that all people working in public health, all nurses working in public health, needed to know how these competencies intersected with, how technology intersected with population health, how we as nurses, if we don't know how to use the technology and use the data and the information, we can't manage epidemics, we can't manage problems that we see in large communities or even global health. Okay, so let's go back to the Tiger Initiative. So Tiger, the Technology Informatics Guiding Education Reform, started in 2007, but they published their recommendations in 2008. They said that the three competencies, again, included basic computer competencies. That includes how to use computers, how to use PowerPoint, how to use Excel documents, spreadsheet documents, how to navigate basic functions on the computer. For most of you, you feel fairly comfortable with that. Now, I know for a lot of people, maybe navigating the internet seems like something that's pretty straightforward, but there's a lot of nurses that have been practicing for quite some time, and maybe they're 50, 60 years old and they don't really know how to use the internet. And basic computer competencies also include things like Excel's, like spreadsheet documentation, which maybe you don't feel so comfortable using. But without that knowledge, you're not able to use data and figure out what patterns are and what the meanings are. Information literacy. This means that you know how to find the right information, that you know that when you go to certain sites like an e-magazine, that it could be published by anybody and that it may or may not have valid information in it, and that going to an evidence-based scholarly journal article is where you need to go to find the right information to support your thoughts or to discount a practice that you've been doing. And many people do not know how to do this. This is something, a skill that even you beginning in your bachelor's degree may not know how to use library resources in order to find the right information to support the findings that you have. Okay. Then information management. Information management means simply that you can take the information and you know what to do with it. So it's not enough just to be able to find the right information, but once you've found it, how do you effectively use it in order to advocate for your patients, to teach coworkers that the reason why this practice needs to change is because even though they learned how to do it 10 years ago like this, that it's something like, oh, what did I see at the hospital the other, when I saw a nurse that was using um, uh, hydrogen peroxide to clean a trach tube. That was an old practice. That is the way we taught nurses how to do it even as recently as 10 years ago. Evidence has evolved now, and we know now that we can't use hydrogen peroxide because hydrogen peroxide, if it gets into the lung tissue, can cause some damage. We don't use anything other than sterile water or sterile saline to clean trach tubes now. But this is, how do I use this information to teach other people? It's not just enough that I know, but what do I do with this information? How do I teach my patients? How do I change my own practice? How do I challenge what I do? Am I sure that I know that this is right? Do I use Lippincott to show that I'm using the most current standards? Okay, so nursing informatics competencies. We talk a little bit about computer fluencies. These are part of those, the 30 that come into the specific competencies for nurses. And nursing fluency means that you understand the technology and the software, the application programs, that's the Excel spreadsheet, and PowerPoint. Information literacy, we talked about the ability to know when the information is needed and how to locate and evaluate it. Critically thinking and problem solving, part of foundation for evidence-based practice. Information management, again, collecting and processing, presenting communication data as information or knowledge. Okay, so Tiger also delineated these competencies by level, and you would be considered beginning. Okay, and this may be somebody who's been out in practice that has not worked very much with nursing informatics competencies, but this is basic information management, computer technology skills, very, very basic. An experienced nurse would be somebody who's highly skilled in using information management and computer technology to support major area practice. So these people are leaders on their unit. They are people that know about how information can be used to support their practice, their unit's practice, um, you know, the how they take care of wounds, maybe how often they need to check on patients, safety protocols. These are people that have had experience working with the technology and how that technology has supported their patients. Then you have somebody who's an informatics nurse specialist. And this is kind of the category where I have worked in, and this is where I would lead projects and be a hospital-wide, an agency leader to transform what it is that nursing needed to be able to apply information, computers, nursing science, and have all of it talk together. Now, I would tell you that one of my main parts of my job was to be able to be a translator between the people who manage the information, people in health information technology, and helping the computer people talk together, and then being the translator for nursing. So computer people know a lot about how the computer works. Information technology people know about how it's stored and how information can be retrieved, like from health records, from electronic health records. And the nurses knew how they needed to use the information for patient care. And unfortunately, because their areas were so specialized, they needed a translator in the middle to be able to talk to each realm so that the best patient outcomes could happen. And that's really what the informatics nurse specialist did. Informatics innovator, these are the people who do research and generate informatics theory about how things should run, to give predictions on how things change. Theory comes into this. And these are, I have conducted research on informatics, but I wouldn't consider myself an innovator yet. Maybe someday I will be, but these are the people who write the textbooks on nursing informatics. Okay, so here's a framework that would be very important for you to know. So when we deal with informatics, we deal with different levels of understanding. Okay, so you look at the way this is stratified here. Data is at the very bottom. Data are just raw facts. So maybe I give you a number like 100. And 100 by itself doesn't mean anything. 100 could be a temperature, it could be a weight, it could be a blood pressure, it could be milligrams of a tablet. You don't know, it's just data. Okay, but there is no meaning to it. Information is the next step where we take data and we give meaning to it. So now if I told you that 100 was beats per minute, and with 100 beats per minute for a heart rate, that at least gives you information. And you can call that, based on your meaning, is tachycardia. Okay, so now we're going to take it to the next step for knowledge. That's where you analyze, synthesize, and derive information. So you take this information, now that you have a meaning to it, and you can put knowledge to it. And a knowledge with 100 beats per minute with tachycardia, you know that 100 beats per minute with knowledge is an abnormally fast heart rate that could be something that needs to be slowed down. I don't know why it could be, but maybe they're anxious. Maybe I can give it. Maybe it's related to anxiety. Maybe it's related to their maybe it's related to pain. Maybe it's because their blood volume is too low and their heart rate's trying to compensate. Then the next level is I'm going to use my knowledge to establish and achieve goals. So my goal, my wisdom, and I don't expect you as nursing students to achieve something like wisdom because this comes with experience. Wisdom with this information and this knowledge now tells me, oh, okay, well, the worst thing that could happen with this, the thing I'm most concerned about with this patient because they're post-surgical, is that they could be losing blood internally that I can't see, which is causing a compensation for the heart rate. Yes, it could be that they're anxious. Maybe they could be in pain because they're post-surgical. But the thing that's going to harm them that I'm most concerned about that I'm going to be watching would be blood loss. And I'm going to be watching for that. And I'm going to be checking more things with my patient, pulling it all together. And I'm going to achieve the goal to be able to reduce that heart rate by making sure that their volume's under control and that I'm watching for signs and symptoms of bleeding. Okay, so here's another concept with technology that's commonly used, and it's called GIGO, or garbage in, garbage out. So we look at data, and to be honest with you, data is really meaningless. You know, we go back to that very low level, that data. And is the data, does it have integrity? That means, is it trustworthy? Can we trust the information that's in there? Was it manually put in, or was it bar scanned in? Was it put in by an experienced nurse or a not so experienced nurse? So these are the things that we need to be thinking about. Dirty data is another concept in nursing informatics, and that's dirty. Dirty information is just information that is old, or it's wrong, or it doesn't have valid sources, and these are the things that you can't figure out. Another concept would be data mining. Data mining is where maybe we have an outbreak of measles in the hospital and we're trying to find patterns. We may go digging through the information to go through all of the history and physicals. Do we go back through all the immunization records to see who was current on their immunizations? Maybe they went to a common restaurant where someone was all, where they all might have contracted it. These are all things that would be helpful for us to know. And we talked about the difference between data versus information. Again, data is just raw pieces of information, raw pieces of, of points, and information is where we make meaning out of it. And in this slide, I just wanted to kind of show you that although the big green arrows kind of show that this inputs and outputs of information kind of are cyclical, they're also connected in a web. You'll see in the middle where all these points are all connected to each other. So the physician talks to the nurse, talks to the computer, the health information, the healthcare, electronic healthcare record. Maybe we try to find meaning by going to the library and looking up sources or the information with evidence-based journal articles. We bring that information back to the patient talks to the doctor, but any of these points can all go back to each other, and it's all a feedback system that all is interconnected. So last week we kind of we began the conversation about to err is human, and that is that landmark study that showed where the 44 to 98,000 people die every year based on healthcare errors. And there's 6 dimensions from the Institute of Medicine that define what quality is. And quality is safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. I'm going to post a link for Dr. Don Berwick, who will define these in detail, but essentially the safety part is that are we doing what we can to make sure above all the patient is safe? The next thing, is what we do effective, or are we just spinning our wheels doing stuff because we've always done it that way? Patient-centeredness. Are we doing it for us? Are we doing it for a policy? Or are we doing it because it's the best thing for the patient? Does the patient want what we're doing? And by wanting, they have to know why they're getting it. If we don't tell them why they get it, they don't understand that they have choices where they don't have to do it. And if it makes them feel comfortable, if it makes them feel uncomfortable, how are we directing quality health care toward what their needs are? Are we meeting, maybe they're very anxious, they've had surgery, maybe, are we focusing on the wound when we should be working on their depression? Maybe they're worried about finances, maybe they're worried about, maybe they're anxious about a loved one at home that they were the main caretaker. What are we doing to help that patient where they're at, what their needs are? Timeliness. Are we getting them at the point in time where they can be benefited the most? Are we working on preventive medicine? Are we trying to keep them out of the hospital? Are we working on that goal? Or are we just putting it off because we don't want to pay for it now and we end up paying more later? Which brings us to efficiency. Do we have are we talking to the right people and orchestrating this care to make it work the best that it can? Or are we redoing a lot of tests, a lot of procedures because we don't communicate very well with each other? Equity. I think equity is probably the most important part of quality, because that means that whatever we give to one person, we give to everyone. And that doesn't mean giving them the most expensive health care out there. It means that the basic stuff is provided to everyone. And all dimensions rely on this quality information. And again, I will post that video online. We can't talk about this in class because we're not here, but I want you to think about how nursing informatics could help in patient care for each one of these qualities. Think about that. Talk with one of your friends in class and think about those things that we can do. We can pick this up when I come back next week and talk about that. Informatics value. The reason why informatics is valuable is because it increases the accuracy and the completeness of the patient's care. We can document what happens. We can improve workflow because it's right there for everyone to see. It's not isolated on a piece of paper. It's in a computer system where everyone has access to it, that should have access to it. So it reduces that redundancy and, like I said before, increases the efficiency. It's automated in its collection of certain things, and it reuses a lot of the data in multiple places. I know, like in the Meditech system that I use at Sacred Heart, if we collect a blood glucose level through the scanners, once it gets docked on the reloading machine, it automatically gets uploaded into the Meditech system, where it goes to several different places in the hospital. It gets flagged at the doctor's office, it gets flagged in labs, it gets flagged for the nurse. It comes up as a warning for the nurse if it's out of range. Many things are there for it to be able to use, and plus it's because it's automated, it'll trigger a lot of announcements like that for the people who need to have it. Facilitating an analysis of clinical data. There's many people that require us to track this data, and many of it is really hard to analyze. Joint Commission has indicators where they say that what good care looks like. Things like that we manage pain, things like do we not readmit patients within 30 days after a discharge, whether a patient dies within 30 days after a discharge. Then you have core measures. Core measures are also quality indicators that we look at for certain things like surgical site infection rates, pneumonia rates for ventilator patients, central line catheter infections, urinary catheter infections, things of that nature. And then there's some federal and state mandated data as well that we look at. There's several different organizations. The largest organization out there would be the International Medical Information Association. That includes, it's medical, so it's primarily physicians, but it also includes some lab people, some health information HIT people, health information technology people, and some nurses as well. Healthcare Information and Management Systems Society, that one's also very large, but it has fewer physicians, it's less global. And then AHIMA, which is the American Health Information Management Association, which tends to be primarily those people that are in HIT. From a nursing specific groups, many of these of which I'm associated with, the Nursing Informatics Working Group is a large consortium of nurses across the globe that work on informatics problems, specifically with global health and how to transfer information from country to country. European Federation of Medical Informatics Nursing Work Group, which is a very similar, but it's focused more on European. The European Union, then the British Computer Society Nursing Specialist Group, and the Alliance for Nursing Informatics. We'll go back to nursing fluency databases, collection of data organized and structured in such a way that selections from it are retrievable singly or as a group. And that's really important concept for you to understand about databases, because databases require that not only does the information go in, but the important part is it doesn't matter whether it's in there. If it's not structured in a way that we can't get the information back out where it gives us meaning and direction, it's virtually useless. So It has to be usable. So here's a question for you. Creating databases, true or false? The first step in creating a database is to identify the pieces of data needed. And that would be false, because when creating a database, the first step always is to identify what research question, what question in healthcare that you want the data to answer. So if you don't have a question built, you don't really know where you need to go. So it doesn't really matter what the pieces of data are. You don't start with the data, you start with the question. Here's some very basics about databases, just in general, that you have different fields, you have different, the whole general grid is called a table, and the fields are just the titles up at the top. And then you can get each distinctive piece of each one of those squares is just a piece of data. Across a row would be a record. So just for pieces that you might need to know. Okay, so data manipulation. When we talk about sorting, we're talking about rearranging records in a table based on data in fields. So you have some primary, secondary, and tertiary levels. And here is a piece of a health information record. And as you can see, we have information from a patient record here, and you'll see that this is just an example. There's no reason to kind of look at this as a whole, but this is just an example of a med record from a patient file. And you can see here that where the fluids and the medications are all in one list, and we can kind of look and see how much this patient has gotten over time. We can look how much, for instance, how much in that first line here with the fentanyl, where the patient has an analgesic drip, you can see where this is a constant rate here, but if there was a patient-controlled analgesia where they're pushing a button, you could over time look and kind of analyze to yourself, oh, this patient's using a lot more than they normally do, they're not needing very much, I wonder, but they're still complaining of a lot of pain, I wonder what's going on with that. So it's just a place where you can use fields and records to be able to kind of tell what is going on. And you can also do queries. Queries just means that you're going in there to go look for information, and you're asking the database to provide you some answers. So the most meaningful tool, one that you might be familiar with, would be something like a Boolean feature, where let's say you go on Google and you're looking for something about maybe how you're going to do your nursing care plan. So you put in nursing care plan, and maybe you found that you're getting too much information, it's not narrow enough, and so your Boolean features maybe have to be limited, or maybe you're not capturing enough. And like in Boolean language, let's say if you wanted to look for something with pregnancy, you may want to look for all things with that word pregnancy in, but maybe putting in pregnancy limits it because you'll miss words like pregnant. Now, Google is a really smart database, and its logistics are advanced enough where it can do that, but if you went into the library and did that, you would not capture the information that includes pregnant or something like that. So if it didn't say pregnancy exactly, you would miss all of those terms. It just wouldn't capture it. So you'd want to put in most of that word up to pregnant, and then put an asterisk there, and then it would allow you to bring in all the words that have pregnant and pregnancy. Limiting factors, available data, user. The limiting factors are the things that keep you from manipulating the data. So if there isn't data out there, that's going to be a challenge to manipulate. We had that problem when we had a new database feature when we upgraded to Meditech at Sacred Heart in 2010. The problem was it didn't interface with the old system. So everything from 2010, it went all the way back into patient records up to 2010, but in 2011 it didn't go back very far, so there wasn't very much available data that could be searched. User's imagination, again, not knowing all the different words that you can try to get the best output. Ability to use criteria selectors or Boolean algebra and symbols and mathematic operators. You'll see table 9.2 in Sewell and Thede, and that'll give you kind of an example of what that looks like. Here's an example of a query in a standard medical record that you may see, and if you were looking for something, you weren't sure where to find it, this gives you several different fields that you can try in order to find these. So there's 5 rights of knowledge, and this comes from McGonigal and Mastrian, which is another health informatics textbook. And so these 5 rights of knowledge depend on the right information. So you have to be looking for the right data and the right information, that it's accessible by the right people. So is it a new nurse, or is it an experienced nurse, or is it somebody in lab that's looking at the information in the right settings? So does somebody in a clinic see something that somebody in acute care doesn't see, or maybe in long-term care? Applied the right way at the right time. So if we're finding the information after the fact, after a heart attack, or after a sentinel event, it's not the right time. And in the right way means that we're looking for the information in a way that gives us meaning in the context that we're using it. So I hope that helps you understand why nursing informatics is actually a very powerful statement. Information literacy, again, this is about how we find information, knowing the right places to look at it, and how it fits into evidence-based practice. So information literacy is just the awareness of the need for information, the ability to find it, ability to analyze and its validity and relevance, and its ability to interpret it for use. Where health literacy, as opposed to information literacy, is just a subset of information literacy, and it's really just the ability to process and understand basic health information and services needed to make appropriate decisions. You know I talk about my parents a lot, but where they find information on the internet is not always appropriate for their health conditions or for their health status. And it doesn't necessarily, I always have to kind of oversee where they're finding their information, because it's not evidence-based sources where they're finding their information. And we need to be accountable for that and guide our patients in the right way. You're going to be surprised how many times patients will look in the wrong place for information. The internet. There's websites related to laws, regulations related to practice, nursing care, healthcare agencies, anyway, on and on and on. Just so that you know, there's lots of websites out there. Some of them are valid, some of them are not. Some of the things that control laws, rules, and regulations is an agency called the National Council of State Boards of Nursing. That's where you can go to see all of the links of U.S. State Boards of Nursing and information if you want to take your boards in another state. There's certain laws that cover you in some states but not in others. Sometimes we have a consortium between the states. We have a collaborative agreement between Wisconsin and Minnesota and other states if you get a license here. You don't have to take the state board in those related states. You just have to apply, but that's not true with the states that are not in that collaboration. So that's a site where you can go to see what the state board's scope of practice is for each state, which is different, even if we have a collaboration agreement with those states. Joint Commission is an agency that gives accreditation to hospitals. It is a voluntary accreditation. Hospitals do not have to abide by it, but they do because the public knows that if a hospital is not certified by the Joint Commission, that they don't follow the rules of meeting the best standards for a hospital. So hospitals pay a lot of money every year to have Joint Commission come through and give them accreditation, which lasts for 3 to 5 years depending on the agency. Centers for Medicare and Medicaid, again, these agencies require certain regulations to be followed for reimbursement of funds for people who have disabilities or are 65 and over. And whatever Medicare or Medicaid says, CMS usually dictates what other insurance companies will cover. So if CMS won't cover it because they say this isn't evidence-based, other insurance companies will not follow suit. So individual state departments of Health and Human Services, Wisconsin Health and Human Services is ours at DHS, Wisconsin DHS. And they give outlines for home health care, long-term care. When they say the state comes into the nursing home, that's who they're talking about. They have state oversight to see how long-term care facilities are managed, and they have certain laws and rules that they follow. Information literacy continued here. It's necessary for lifelong learning. You have selected a career that requires you to always learn. So even when you're done with school here, you will always have to learn more about nursing because it changes all the time. And it's probably changing faster now than it ever has changed in nursing history. So if you don't have a love for learning, this might not be the right field for you because you're never done. You're just never done. The need in this lifelong learning is from a domain knowledge, not just in nursing, but also how computers work, because I guarantee you computers will change in your lifetime, and the way we gather and retrieve information will change. Clinical experience obviously will change because technology for patient care will change. Functional understanding of search skills will also certainly change. And the ability to analyze and integrate knowledge and apply it to practice and practice settings. So we have to be able to make sense of the data, and that's going to evolve as well. Evidence-based resources online. There's a lot of information out there. Variability on quality, just be aware of that. I offer you that there's some websites found in the libraries in evidence-based practice centers. There's also a table of clinical practice guidelines, table 10.2 in your textbook. Critical thinking, this is supported by information literacy. There's two components of critical thinking. One is the skill to process and generate information, and the other one is the intellectual commitment to use the skills and guide behavior. There's nothing more important than your ability to critically think. It is the essential part of being a nurse. It means asking questions. It means being aware of your gaps, what the gaps are for your patient, thinking about what's wrong with this, what's the worst case scenario, what could go wrong with this. And if you're not asking those questions and trying to dig deeper with your patient, you're not asking the right questions. Never settle for what is right in front of you. Always dig a little deeper. And the results are directed toward improved outcomes. So whatever you're doing, work toward making things better for your patient. For your patients, it's important for discharge planning and patient education. We've talked about this, that you start discharge planning at admission. So education materials should be written no higher than 5th grade level. Include non-written materials if possible. Pictures are a lot more helpful for your patient. There's something called a Fleisch-Kincaid grade level for readability. That's very useful. If you have Microsoft Word, you can search in there, but you can type something out and you can do a Fleisch-Kincaid readability scale on that, and just put readability scale on there, and it'll pop up what the reading level is for what you just typed. And we tend to write higher than where our patients can read. So just so that you know, if you're writing for somebody in your class, you're probably writing too high. Information management, this is how we use our information, especially in electronic health records. Our documentation, how we use that information. Verbal communication, how we communicate within nursing, how we communicate outside of nursing, and also with patients, families, and other caregivers. Data collection, how do we manage the information when we collect it? Do we leave it on our clipboard and document at the end of our shift? People can't see your information if it's on your clipboard, if it's not in the electronic health record, so that you're not going to be able to know what you know because it's hidden on a piece of paper. Are your assessments thorough? Are they accurate? Are your reports subjective rather than objective? Some of the risks for informatics is that nurses in general right now do not have skills. They don't know much about informatics and they don't understand why it's important for them to understand how the information that's there for their patient can be used for their outcomes. They don't associate it with patient quality. They look at it as a chore rather than something that's essential for their patient. It's not just for your information or to save yourself from liability, which is one function of it, but it's also to communicate with other people who could be looking at that chart. Healthcare systems without access to advanced IT resources have limited abilities to understand the risks. They don't see what agencies that do have the resources. Most long-term care facilities in our area they don't have interoperability, which means that they don't communicate with outside computer systems very well. So they can't see what other agencies know, and that's a problem. Patients that can't communicate with informatics, in the last year and a half, the Centers for Medicare and Medicaid have mandated that hospitals, not long-term care, hospitals initiate like a patient portal so that patients can access their records. I know Marshfield Clinic and Sacred Heart and St. Joe's and Mayo System all have initiated their patient portal systems now, and patients can go in and look at their labs, they can look at their blood pressures, their medications. It's limited information, but it's still information that's out there, and it's a good thing. They can access it a variety of ways through smartphones, internet, and telehealth, and we'll talk a little bit about telehealth in the coming weeks, which just means connecting with our patients where they are. This is another video I will post on the internet for you. It's a really good site for you. This slide just kind of shows you the variety of different things that are available with the future of informatics and why it's really important. This picture here is just a patient who is connected to a Holter monitor, and his heart rate is wired back to his doctor 24/7, and they can record it for several days if they need to. In this picture in the upper right hand is a physician that's giving in a rural setting, he's giving a physical exam to a 6-month-old baby and showing it to some pediatric specialists. Here you can see the picture of the baby up here, and they're able to give advice and do a consult over a great distance here. This here is a drone that delivers information for an AED out in remote areas for them to be able to do CPR, advanced CPR for a patient, and it's directed and located by GPS. There's some other automated systems that we do with telehealth where we'll talk about this a little in coming weeks here, but we can communicate with patients. They never have to come in. Once a day they can take a blood pressure, take their weight if they have congestive heart failure and they're carrying fluid, if they have blood glucose readings. All of this can be uploaded into smartphones and sent to a central location where it can be monitored by a telehealth nurse who monitors to see whether the patient might be getting into some trouble. So this is where informatics is going, and we can't stop it. It's getting more and more exciting every year. Kind of cool stuff. But this is the reason why it's really important to get educated about all of these. We'll talk a little bit about legal and ethical issues in documentation in the coming weeks, as well as some of the electronic health records. I don't have any way to answer your questions, but if you have any, send me an email and I'll try to answer them from my residency. You guys have a great day.